Hello, today we are going to review the blueprint for atrial fibrillation, focusing on diagnosis, management, and what is truly a new paradigm of care. The key idea is that atrial fibrillation is no longer treated as an isolated rhythm disturbance. Instead, it is understood as a systemic progressive disease requiring structured, multi-level intervention. We can think of this as 10 structural shifts. First, atrial fibrillation is now viewed as a disease continuum rather than a static time-based classification. Second, lifestyle and risk factor modification are foundational, not optional. Third, we move beyond CHAD-SWASC2 and incorporate dynamic stroke risk modifiers. Next, there's a strong emphasis on early rhythm control, catheter ablation as first-line therapy in selected patients, and device-detected Afib. Finally, left atrial appendage occlusion and recognition of medical precipitants highlight a more comprehensive approach to care. Afib should be thought of as a staged disease. Stage 1 is the at-risk population, patients with risk factors for Afib but no Afib as of yet. Stage 2 is pre-Afib, where structural or electrical abnormalities already exist. Stage 3 is clinical Afib, paroxysmal or persistent. Stage 4 is permanent Afib, which is important. It is not a biological inevitability but a therapeutic decision. This emphasizes that early intervention can alter the disease trajectory. We should have a structured framework for Afib management. At the foundation is lifestyle and risk factor modification, what we call head-to-toe screening. Above that are 3 pillars: stroke prevention, optimization of comorbidities, and symptom management. This is sometimes summarized as the 4 A's, ensuring access to all aspects of care for the patient. The core electrophysiological model for Afib: on the left we have triggers, primarily ectopic firing from the pulmonary veins, often driven by calcium dysregulation. On the right we have the substrate, fibrosis, conduction block, and autonomic remodeling. The key insight here is that electrophysiological remodeling is usually a consequence of Afib, not the initial cause. This is why early intervention matters. There are upstream pathways to consider. Renin-angiotensin-aldosterone activation leads to fibrosis and structural remodeling that drives the substrate of Afib. Oxidative stress alters ion channel behavior and calcium handling. Systemic inflammation activates fibroblasts and further promotes atrial myopathy. Clinically, this creates a prothrombotic environment within the left atrium, increasing the stroke risk. Now, we can detect Afib by many different mechanisms. Consumer variables, Holter patch monitors, implantable cardiac monitors, cardiac rhythm devices, all of these are ways by which we can detect Afib. For structural assessment, transthoracic echocardiography is essential. Holter and patch monitors improve the sensitivity. Implantable monitors provide the highest yield, whereas consumer wearables are easy to use and do not require prescriptions. Devices such as pacemakers can detect high atrial rate episodes and must be confirmed to avoid oversensing artifacts. Now, considering obesity and Afib, we should realize that obesity is a major driver of Afib. There is a clear dose-response relationship. Higher BMI leads to higher Afib burden. Importantly, weight loss is therapeutic. Greater than 10% weight reduction significantly improves maintenance of sinus rhythm. This reinforces that structured programs not simple counseling, are essential. Now, to address modifiable behaviors, exercise is beneficial with a target of 150 to 200 minutes per week, although extreme endurance training increases AFib risk. It's a common saying that gold medalists have more AFib than silver medalists, have more AFib than bronze medalists, have more AFib than non-medalists. Alcohol has a clear dose-response relationship. Binge drinking significantly increases acute AFib risk. Smoking increases stroke, heart failure, mortality risk, and must be eliminated. Caffeine, interestingly, is not harmful in typical amounts and may actually not need restriction. This emphasizes treating underlying conditions. Hypertension is the most significant contributor, should be aggressively controlled. Sleep apnea is highly prevalent and treatment reduces AFib recurrence. Diabetes management improves outcomes, especially pre-ablation. Message is simple. AFib management is systemic, not just electrophysiologic. Now we have numerous risk stratification tools for stroke assessment. CHADS VAS2 remains a standard due to simplicity. Atria refines risk assessment by incorporating renal function such as proteinuria, GFR less than 45, and is a better classifier of risk. Whereas Garfield AF integrates bleeding risk as well and mortality risk, smoking and dementia. It facilitates comprehensive shared decision making by giving us an assessment of the net clinical benefit. Now, we have to stratify the patients as low, intermediate, and high risk. Low risk patients have less than 1% risk of stroke per year. Intermediate risk have 1 to 2%, and high risk have more than 2%. Now, low risk patients typically do not require anticoagulation, as the risk of bleeding from anticoagulation is equal to or higher than the stroke risk. Intermediate risk patients are the gray zone. Here we have to consider modifiers such as AFib burden, obesity, left atrial size, kidney function, etc. High risk patients should receive oral anticoagulation regardless of the AFib pattern. Now, what anticoagulation to use, a DOAC or a warfarin? DOACs are first line for non-valvular AFib due to lower bleeding risk and improved safety. Warfarin is reserved for specific populations such as mechanical valves or rheumatic mitral stenosis. Key point is to avoid inappropriate dose reduction of DOACs, as this increases stroke risk. Also, drug interactions such as CYP3A4 and P-glycoprotein must be considered. What about device-detected AFib or atrial high rate episodes? Subclinical AFib can be detected by devices. Short episodes less than 5 minutes are low risk. Intermediate duration episodes require an individualized assessment. Episodes longer than 24 hours significantly increase stroke risk and warrant anticoagulation. Importantly, all device detections must be visually confirmed before treatment decisions. Also, it should be noted that the stroke risk reduction in device detected AFib is not as great as that in clinical AFib. Finally, as we bring this together, the key message is that atrial fibrillation is a systemic progressive disease. Management requires early identification, aggressive risk factor modification, appropriate anticoagulation, timely rhythm control. Early intervention in the disease leads to better long-term outcomes. Thank you for listening. More to follow.